I have the luxury of actually sharing this morning with Dr. Salas, and we're going to get started so we stay on time. Our first speaker is Dr. Lynch, who's going to speak about novel therapies in acute MI and shock. Thank you, Dr. Lynch.
Hi, my name is Steve Lynch. I'm an interventional fellow at Beaumont outside Detroit. This is a case that I did during my general fellowship at Beaumont Dearborn with Dr. Joe Shatahi. So we have no disclosures. I do have to report this is an off-label use of a device of supersaturated oxygen. But basically, this is a novel therapy. It's the use of Impella plus PCI plus supersaturated oxygen in a patient with acute anterior MI with cardiogenic shock. So I'll get right into the case. This is a 58-year-old obese male who presented to the ER with 1 hour of substernal chest pain with no radiation, dyspnea on exertion, 8 out of 10 pain. We know that he had a history of coronary artery disease with 3 stents placed to the RCA due to an inferior STEMI in 2018. This case was in the winter of 2020. So while he was in the emergency room, this was Detroit during COVID times. He was stashed in a back room somewhere in the ER. He was found unresponsive. 8 minutes of CPR were administered. He was shocked 3 times. He was intubated. EKG after ROSC was achieved showed this, anterior-inferior ST elevations. So he was emergently rushed to the cath lab. This is about 10 o'clock at night. We're fortunate at Beaumont Dearborn that we have this supersaturated oxygen, and one of my mentors and attendings is Dr. Spears, who invented the therapy. So as I'm driving in the middle of 10 o'clock at night, I'm calling Dr. Spears saying we have an anterior MI. This may be a good case for supersaturated oxygen. But when we get a little bit about his history, we know about the coronary disease. He was lost to follow-up after that inferior STEMI. He's never a smoker, infrequent alcohol use. These are the medications that he was reportedly taking, but after the fact that we found out that he had stopped taking all of his medications about 6 months after his STEMI. When he got to the cath lab, his blood pressure was in the 80s. He was on 10 of norepinephrine. So we were planning for coronary angiography, left heart cath, right heart cath. We had the Impella on standby. We were concerned for cardiogenic shock. So first thing we did is we went up into LV to get LV EDP, sort of poor man's right heart. And we did a hand injection. Because of the multiple regions that were seen on the EKG, we wanted to know if we were dealing with a LAD or RCA. This shows, it's a hand injection, but it does show the anterior wall, the apex are not moving very well. We call the EF about 25%. EDP was 30. We did a quick angio. It shows moderate disease in the right. And then as soon as this plays, it shows what we were expecting here, which is the mid-LAD is gone. He's got disease pretty much everywhere, though. Some left main disease. He's got ramus, diagonal disease. But we have a culprit. So as I said, LV EDP was 30. We chose femoral access in anticipation of the Impella. We did our angio. I mentioned the results there. So at this point, how would you proceed? This is a shock meeting. We're in Detroit. So first thing we did is we put in the Impella. And we fixed the LAD. We ended up balloon angioplasty stenting with a 3/32 synergy stent. We were not looking for perfection here. We did not treat the non-culprit vessels. We got TIMI 3 flow, and we were happy with that. A little bit about the procedure. After we opened up the LAD, we did a right heart cath. You can see the pressures here, right atrial pressure of 18, a wedge of 25, mean PA of 28, PA SAT of 41. His cardiac output is 3.3, CPO of 0.58, and a PAPI of 1.1. So at this point, how would most people proceed? A lot of the country would just increase the pressors. Do we treat the non-culprit vessels? Do we upgrade to an Impella 5.0? Do we need an Impella RP? At our institution, unfortunately, we do not have the Impella 5.0. We do have an RP, but the PAPI was 1.1, so it didn't quite fit criteria. And like I said, we're fortunate that we have this supersaturated oxygen therapy. He fit the criteria for usage in terms of he came in with less than 6 hours of chest pain. It was a LAD, prox or mid-LAD, which are the current criteria for the use of supersaturated oxygen. It is not indicated for shock, but in discussing with Dr. Shatahi and Dr. Spears, we decided to use it off-label. The patient was in shock, but he was in stable shock that we thought we could infuse this therapy for an hour and watch him very closely in the cath lab. So what is SSO2? It's essentially a circuit where you draw blood from the patient and return blood to the patient, but directly into the left main. But it runs through a console where we are able to infuse the blood with supersaturated oxygen. It is an aqueous oxygen solution where Dr. Spears is able to infuse high pressures of tiny, tiny microbubbles of oxygen into saline, which can be administered into the blood, and we're able to deliver up to 800 or 1,000 millimeters of mercury of oxygen into the arterial system. This oxygen is hyperosmotic to normal blood. Basically, what we're doing is we're able to deliver high levels of oxygen to the microvasculature of the coronary system. Through multiple mechanisms, it reduces the reperfusion microvascular ischemia injury. It delivers oxygen, opens up the blood vessels, delivers blood to the microvasculature. How does it do this? There's a number of mechanisms. It reverses the hypoxia-related capillary obstructive responses to endothelial cells and the blood elements. And the fact that it's hyperosmotic, it reduces the extracellular edema in the myocardium, which opens up the microvasculature. So to do this, you either need to have a 7 French sheath that you can draw from and infuse through the catheter, or you have to have 2 5 French sheaths. Our procedure, we did single access impella. We did the infusion catheter through the 6 French sheath through the impella sheath, and we drew from a 5 French sheath in the left femoral artery. This is the setup, but essentially it's a circuit that you draw blood from the patient, you run it through the console, you connect everything wet to wet, and then you infuse directly through a 5 French specialized JL catheter directly into the left main. You infuse for 1 hour. You take a picture or an angio at the end to make sure there hasn't been any damage, and then you take the equipment out and send them to the unit. So our right heart cath numbers I mentioned before the Therox therapy. We did a right heart cath immediately after the supersaturated oxygen therapy, and here you can see the numbers. Our PA pressure, the mean PA went down by 21%, the PA sat went up by 20%, cardiac output went up, cardiac index went up by 20%, CPO went up, taking him from a range of needing escalation to not needing escalation. That's after 1 hour of therapy. We got an echo first thing in the morning. This is 6 hours. Still had the impella in place. And this is the echo, that we get worried about with these anterior MIs. The apex is starting to look a little thin, maybe even dyskinetic. On day 2, you can see that apex in the LV is already starting to recover. It's looking thicker. It's starting to contract. At 21 days, essentially a normal LV here. And we saw the patient in follow-up at 6 months, and again, normal LV. He did have a bit of a prolonged stay, complicated by pulmonary issues. He's a beast guy. He had hypoventilation syndrome. He had tracheal stenosis after he was extubated, requiring reintubation, but he is doing well at this time. So this is just one case, basically case number 0 of SSO2 delivery in addition to the impella and to PCI for anterior MI with cardiogenic shock. We saw acute improvement in hemodynamics after the 1 hour of therapy. We saw a remarkably rapid restoration of LV systolic function with prolonged preservation of function. This is sort of a preface to an upcoming trial that's going to be run by our friends at Henry Ford, Dr. Bashir and Dr. O'Neill, called the ISO shock trial, where they will be looking at exactly this therapy. It's going to be 60 patients randomized to either impella plus PCI or impella plus PCI and supersaturated oxygen in patients with anterior MI, less than 6 hour onset, and cardiogenic shock. And some references, and just like to thank my mentors and the other fellows involved in the care of this patient. And thank you for your attention, and I'll leave with that.
Dr. Lynch, moderator's privilege, because I'm going to ask you to speak just a little bit more and then cut you loose here, so I'm going to let the rest of the group talk. 2 questions. Number one, you commented on the PAPI, and that was part of the initiation for this. You had a lot of haziness, before the RPLV and the PDA. Was there consideration of actually doing further analysis of that? And the other question is that, you tried to infer that there was a significant amount of causality related to starting supersaturated oxygen an hour later. Kind of flies in the face of some of the molecular biology about what would be best for that heart long term. What's the long-term surrogate endpoint y'all are going to use in that trial?
This trial is going to be 30-day mortality, and then they're going to be looking at infarct size through MRI.
Okay. Panel?
Yeah, very good study. I don't have experience with this therapy. I know that prior study from New York showed decreased mortality and decreased incidence in heart failure for this study. That was in non-shock patients without cardiogenic shock. And I think that was prospective, small sample. The question is the toxicity of high level of oxygen, the hyperoxemia. It's very well known that when we deliver oxygen to the lungs, we have local toxicity, also neurological toxicity and hyperoxemia. And some reports, I think, that showed vasoconstriction of the coronary arteries when you have high level of oxygen. So I don't know exactly if we have a safety profile of the therapy. That is one of my questions.
Yeah, it's a very good question. The safety profile, it is concerning because you're leaving a catheter in the left main for 1 hour and you're infusing high levels of oxygen into the blood. But we have done, or I shouldn't say we, but Dr. Spears and others have done extensive studies, including hundreds of patients, and really there have been no reports of oxygen toxicity with any of these patients. In our time at Dearborn, we've done about 20 patients. We've had no safety problems with the device, and in the preclinical and clinical studies, there were really no significant adverse events.
But how would you know? So I mean, the point is that you would worry that oxygen toxicity is worsening reperfusion injury at the microcirculatory level. So I understand there's nothing that you can see, but I guess I'm really glad you're doing a trial to see whether this really works. And it's a lovely case, it's a lovely therapy, but people really do get better when you support their hearts and open up their occluded coronary arteries. So maybe the supersaturated oxygen makes that better, and maybe it doesn't. I'm really grateful that you guys have planned to do a trial with a good outcome, like 30-day mortality.
Yeah, I will say that this therapy has been proven in anterior MI, not with shock, to reduce infarct size by 26%. Absolute reduction in infarct size by over 6%. It's the only therapy that's ever been proven to do so. And that's why we decided to use it. Opening the vessel, I absolutely agree, is the most important thing. Unloading the ventricle, also very, very important. This is an adjunct that we're really trying to fine-tune and reduce that infarct size.
But the question, raised here was, you have dual effects, the osmotic effect and the hyperoxic effect. So one may be deleterious, one may be beneficial, the two may be beneficials. So it would be interesting, at least in preclinical trials, to look at whether in isolation, having hyperoxic but without hyperosmolar effect, hyperosmolar effect without oxygen, and of course your product there, to see the differential effects of all. Because as mentioned by Steve, we know that indeed in cardiac arrest, the brain doesn't like hyperoxia, the heart doesn't like hyperoxia. And all we do usually is to limit the hyperoxic effect after recovery of cardiac arrest. I guess the same may be observed for the heart. So either we have some improvement because the reperfusion was not complete, and by increasing the PO2, you increase the diffusing aspect of oxygen and you improve the recovery of the cells. But this is limiting the ischemic event, not the reperfusion event. But for the reperfusion event, as mentioned by the three of us, you have deleterious or detrimental effect usually of hyperoxia.
Dr. Lynch, thank you.
Thanks.